Good afternoon. Thank you for attending this month's Ocean Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to have Dr. Blair Darney and Emily Boniface of Oregon Health and Science University and Fran Beal of Ocean here to present Community Health Centers are key access points for contraceptive services for women with low incomes in the U.S. Dr. Blair Darney is a reproductive health services researcher. She earned her PhD from the University of Washington School of Public Health, completed an ARC postdoctoral position, and worked for the Mexican government for several years. Her work focuses on access, utilization, and outcomes of maternal, contraception, and abortion services. Dr. Darney has an active program of research in Mexico where her work and collaborations focus on abortion, adolescent birth, and contraception. In the US, she leads studies focused on access, utilization, and quality of contraceptive services in safety net clinics in the US and reproductive health outcomes among Latina immigrants. Emily Boniface is a biostatistician with the Department of Obstetrics and Gynecology at Oregon Health and Science University. After working in basic science research for more than a decade, she transitioned into public health research in order to pursue her interest in sexual and reproductive health, particularly among adolescents. Her long-term career goal is to use data science and rigorous methodology to increase understanding of women's sexual and reproductive health with the hope of reducing disparities in those health outcomes. Her work with the Obstetrics and Gynecology Department encompasses all levels of statistical analysis, from developing analytical plans to cleaning, to analyzing, and to disseminating data, and on both observational and interventional studies of all sizes. And finally, Fran Beal is an epidemiologist and data analyst at Ocean. She holds an MPH from Oregon State University and an MS from the University of Pittsburgh and has been at Ocean for 2 years. Prior to joining Ocean, she performed obstetric research at OHSU. This session is being recorded. Attendees are muted upon entry, but if you are not, please mute your microphone and pose your questions through the Q&A or chat box. This presentation will last approximately 45 minutes with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Blair Darney, Emily Boniface, and Fran Beal for Community Health Centers are key access points for contraceptive services for women with low incomes in the U.S. Dr. Darney, Emily, and Fran, the floor is yours.
Thank you very much, William. Thank you to the team involved in Ocean Grand Rounds for this invitation and the kind introduction. And thanks to all of you attending today for your time. I'm just going to dive right in because we've had that wonderful introduction. So today, I'm going to give a little context for this body of work around contraceptive services in community health centers by laying the groundwork around unintended pregnancy and publicly funded contraceptive services. And then the goal today is really to give a high-level view of a program of research that's grown over the last 8 years in collaboration with Ocean and OHSU, looking at various questions around contraceptive services in the safety net. And I'm going to close just with a few ongoing and future directions, because I think there's a lot of really exciting potential to continue this line of work with Ocean in advance. So unintended pregnancy is a key population health indicator. It's part of Healthy People 2030. It has been a key population health indicator through various iterations of Healthy People throughout time. And that is due to the health and psychosocial and economic and educational consequences of unintended pregnancy that have been well documented for both women and infants and families. And it's also important to think about unintended pregnancy as a marker of other social and health inequities. So unintended pregnancy may cause health and social outcomes. It is also caused by existing health and social inequities, right? So the causal relationship with unintended pregnancy is not entirely clear. And it's one of those questions that we may never really know the causal answer, since it can only be observed in an observational way. And then I always just like to frame unintended pregnancy beyond any health and social consequences as a human rights issue. The right to decide whether, if, and when to have children and have a family is enshrined in the UN human rights law and really came to the fore in the sexual and reproductive health field at the 1994 Cairo Population Conference. In the US, the proportion of pregnancies that are reported as unintended has declined over time. In the estimates from 2011, 45% of pregnancies were reported as unintended, which was down nearly 20% from the 2008 estimates. These estimates all come from the National Survey for Family Growth, or NSFG, which is our large population-based demographic survey. I'll just take a moment here to note that I will be using the words women throughout this presentation, and we have limitations in data, in OCHN data, which I'll get to, but even going to our population-based survey data, where respondents who answer the module around history of pregnancy are identified as women. So I'll be using that terminology, recognizing that it doesn't include everyone capable of experiencing pregnancy. And then when we look at unintended pregnancy in key subgroups, we start to see disparities. So unintended pregnancy overall is declining. However, inequities in unintended pregnancy are widening. So for example, among adolescents, 75% of pregnancies were reported as unintended in 2011. And then if we look at income, this graph shows both income and race ethnicity. And income is, FPL is on the x-axis, and this is the unintended pregnancy rate. So per 1,000 women of reproductive age, a different way of thinking about unintended pregnancy than the proportion of pregnancies, but the story remains the same. We see that there is a clear gradient by income, with women with lower incomes experiencing higher rates of unintended pregnancy. And then within those income groups, we also see inequities by race, ethnicity. And for me, these disparities and inequities in unintended pregnancy really tie directly to the CHC population that is served by OCHN clinics and by the entire Advance network. Turning to publicly funded contraceptive services, we have in the US a very fragmented family planning safety net. The US health system overall is very fragmented, as we know, and then within that, family planning services are very patchwork and fragmented. The Medicaid program, with which you're all familiar, funds about 3/4 of the publicly funded family planning services in the country. However, not everyone is eligible for Medicaid, either due to income restrictions, immigration status, or other reasons. And so there are some other programs that fill in these gaps, notably the federal Title X program, which I'll give a little more detail on in a moment. And then there are also state level family planning programs, which are implemented either as 1115 waivers from Medicaid or then transitioned into state plan amendments under Medicaid that use state dollars to complement federal Medicaid funds. In Oregon, this program is known as C-Care. In California, it's known as Family Pact. So many states have these state family planning programs that also, where the goal is to fill the gaps left by Medicaid. Turning specifically to the federal Title X family planning program, which is run out of the Office of Population Affairs, we can see here, again, this is the characteristics of clients who use services at Title X clinics. And we can see that over 85% are women with low incomes on the left. And then we can see that nearly half are women without insurance. So again, this maps very clearly onto Title X clinics, but maps well on to the OCHN Community Health Center population as well. Title X is also an important program in that it implements a set of quality standards for the quality of family planning care that's provided. So Title X grantees, which sometimes are states, departments of health, and sometimes, for example, in some states, Planned Parenthood was a Title X grantee, and you may have heard about that in the news under the defund Planned Parenthood kind of rhetoric. And the quality standards really grew out of this seminal report in 2014 that set standards for the quality of family planning services by the US Office of Population Affairs. And so in brief, what Title X clinics need to comply with in order to receive funding is offering a range of FDA-approved methods, implementing client-centered non-coercive contraceptive counseling, And also there's an element of provider training. So the Title X program not only provides funds to subsidize services for clients, it also provides funds or other resources for training for providers to be able to provide contraceptive services. And whether that's around counseling or specialized clinical services like IUD insertion or implant insertion. All right, so with that background, kind of laying the context, we're going to jump into this high-level review of some of the work that we have been undertaken between OCHIN and OHSU. And this first paper came out in 2020, but grew out of a collaboration that started back in 2013. And so you can see that sometimes things take a while to get started is the first lesson. And the second lesson is that this has just really been an evolving passion place of mine. And I've been so grateful to work with the team at OCHIN. You'll see some familiar faces, names on this article. So first, we just wanted to know who's paying for services. I just talked about publicly funded family planning services, and we know overall, and we know what happens in Title X clinics because they report up at the clinic level, but we to the Office of Population Affairs, but we really didn't know across CHCs what that payer mix looked like. And we especially were interested in ACA, in Medicaid expansion, Title X, and the state programs, which I just outlined. So we wanted to know a very seemingly basic question. Did more women use insurance to pay for contraceptive visits in the safety net following Medicaid expansion? So our outcome is just an uninsured visit for any contraceptive service. You'll see us looking at different outcomes as we go through this presentation. Sometimes it's a particular service or a particular contraceptive method. This is global contraceptive services. So it could be counseling, it could also be provision of methods. So we see here in this graph that Medicaid expansion resulted in a decline in uninsured contraceptive visits across the safety net. And we see that in both non-expansion, which are the top dots, and in expansion states, which are the bottom dots. However, the gap in uninsured visits between expansion and non-expansion states widened after ACA implementation. And in terms of why we see uninsured visits going down in non-expansion states, you have to remember too that more women were using private insurance to pay for contraceptive services after Medicaid expansion, and not due to Medicaid in the ACA, not due to Medicaid expansion, but due to what's sometimes known as the contraceptive mandate, that private insurers had to cover contraceptive services just like they cover other preventive health services. All right, so then we were able to see that using insurance for contraception is increasing after the ACA. And next we wanted to know, okay, well, what are those services like after Medicaid expansion? And this paper is part of Erica Cottrell's R01, the Every Woman Project. And I've been leading contraceptive work, which is just a piece of that larger project. And I want to thank Erica for her leadership on that R01 and the opportunity to participate. So here we wanted to know, was Medicaid expansion under the ACA associated with improvements in contraceptive use quality metrics across the safety net? So here, our outcome is use of most and moderately effective contraceptive methods to women at risk of pregnancy. And I'm going to explain a little bit the quality metrics and these measures a little bit more. So the Office of Population Affairs has implemented and had endorsed by the National Quality Forum a set of quality metrics for contraceptive care. We did not have any quality metrics for contraceptive care prior to these. So that in itself may be surprising, and these are relatively new. So the metrics focus on provision of moderately or most effective methods. Moderately effective methods are your short-acting hormonal, primarily oral contraceptives, but also other types of short-acting hormonal contraceptives. And most effective are what's known as long-acting reversible contraception, or LARC, which is the intrauterine device, or IUD, and implant, and also includes sterilization. However, given the services that are provided in CHC clinics, we do not examine sterilization in our work. We focus on LARC. And the denominator for this metric is women at risk of pregnancy. And the metric was designed to be used with claims data, because that's really what we mostly have access to across the US. However, with the OCHIN and advanced data, we are able to identify more accurately who is at risk of pregnancy. And actually in a calendar year, because the metric is also designed to be an annual rate, we can even have women moving in and out of the denominator, right? If a pregnancy ends and they again become at risk for pregnancy. So we're able to look at it in a more nuanced fashion in the EHR data. And it's really important to note that this metric is a measure of access. There's no threshold, right? For some other common preventive health services, such as H1B, A1C, you know, the expectation is that 100% of people in need of that service get the service. But contraception is a voluntary health service. And so there are no thresholds here. And the metric is designed to be used over time to identify inequities. If one group has high rates, another has low rates, why is that? What's going on? Or geographically, if there are differences in rates, what's going on? Or by insurance status, et cetera. So jumping into the results from this paper, I'm going to focus on the right, which is the most effective for LARC methods. And here we've grouped IUD and implant. And on this graph, we're looking at both Medicaid expansion and Title X. You're going to see Title X coming up over and over because it's such a key part of access to contraceptive services for women without insurance. So at the very top, those are Title X expansion states. And you can see 2013, 2014, and then going into 2016. And that's the proportion of women at risk of pregnancy who have received a LARC method. And below that is in yellow are expansion states that are not Title X. And you can see at the very bottom in the yellow squares, the non-Title X, non-expansion states, where it would appear from these results that access is a lot lower access to LARC than either in Title X clinics or Medicaid expansion states, or really places that are both, right? So Affordable Care Act sponsored Medicaid expansion was independently associated with a small but meaningful increase in access to the most effective methods of contraception. And to note here is that the Title X program is playing a really key role in those non-expansion states. That's the blue squares. So women who are living in places where Medicaid was not expanded are relying even more on Title X to fill the gap, which makes sense. I'm going to turn it over now to my colleague, Emily, who led this analysis and the paper about a special case of community health centers, school-based health centers.
Thanks so much, Blair. Next slide, please. Okay, so I'm going to start with just a quick overview about school-based health centers. These clinics that are located at and sometimes nearby school sites around the country offer accessible and affordable healthcare to students regardless of insurance status or ability to pay. All school-based health centers in the country provide primary care, and the majority of them also provide other services like behavioral health care and dental care. And then also importantly for our study, some of them provide sexual and reproductive health care. Our study focused on school-based health centers in Oregon, which has a particularly robust school-based health center system. The first school clinic was established in 1985, and currently there are more than 70 certified school-based health centers located across the state. One of the really important things to note about school-based health centers is that decisions are often decided at the state or the district level, so services can really vary by location between these clinics. And that is particularly the case when we are discussing contraception provision on site. More than half of school-based health centers across the country are explicitly prohibited from dispensing contraceptive methods on site. And so Oregon is not necessarily representative of school-based health centers nationwide because there are quite a few school-based health centers in the state of Oregon that do dispense methods in clinic. Next slide, please. So one of the reasons for this is that the Oregon Health Authority, which is the body that certifies the school-based health centers in Oregon, recommends that all clinics provide on-site contraception as a clinical best practice. And if for whatever reason a health center opts not to dispense those methods on site, then they have to refer to other providers. And within the school-based health center system in Oregon, clinics can choose if they want to participate in the Title X program. And if they do, they have to meet the program requirements, which includes on-site provision of a wide range of methods. So as of 2018, 60% of school-based health centers in Oregon dispensed at least one contraceptive method on site, and condoms and pills are the most common. Next slide, please. So in this study, we wanted to know, how has provision of the most effective contraception methods, and again, here we're talking about IUDs and implants, changed over time at Oregon school-based health centers? And also we wanted to know what role the Title X program played in that provision. So the outcome for these studies is provision of IUDs or implants for adolescents. And here we define adolescents as 14 to 19-year-olds. Next slide, please. So here we see how contraceptive method mixes has changed over time at school-based health centers from 2012 to 2016, which we see in the horizontal axis at the bottom. On the vertical axis on the left, we're looking at the percent, and this is the percent of adolescent contraception provision visits. So it's not all adolescents or even all SBHC visits, but visits at which a contraceptive method was provided. So provision of implants, which we see in the light blue line, increased over the study period about 6.5-fold, from just over 1% to more than 7%. And then provision of IUDs, which we see in dark blue, increased about 5-fold, from just under 1% to about 4.5%. And then at the top in green, we see provision of hormonal methods, which decreased over the same period from about 94% to about 80%, but you can see it's still by far the most common method provided at these clinics. So when we combine IUDs and implants, that means that overall provision of the most effective methods increased from 2% to almost 12% over the study period. And it's worth noting that these trends were much more pronounced at Title X school-based health centers than at those that didn't participate in the Title X program. Next slide, please. So here we're explicitly looking at the role that the Title X program plays in provision of the most effective methods. So the outcome here is the adjusted probability of providing a IUD or an implant at an adolescent contraception provision visit. So it's the same denominator as the previous slide. And when I say adjusted probability, that just means that when we calculate these probabilities, we're taking a lot of other factors into account. So here we're including individual, visit, and clinic level factors. One of the clinic level factors that we included was the presence of Planned Parenthood in the county, which we use as a proxy for other sources of family planning services that adolescents may have access to. So on the right, we see the adjusted probability of providing an IUD or an implant at a Title X clinic, which was 4.4% over the full study period, so from 2012 to 2016. And then on the left, we see that at non-Title X clinics, it was less than half of that at 1.7%. So what we found in this study is that adolescents have expanding access to IUDs and implants in school-based health centers over time in Oregon. And also, importantly, that participation in the Title X program can help further increase access to effective contraception in Oregon school-based health centers. And I will turn it back over to you, Blair.
Thank you, Emily. So you've heard a lot about the Title X program in the work so far, so it may not come as a surprise that now we are turning to our most recent paper that focuses specifically on Title X. We've seen Title X in conjunction with Medicaid expansion. We've seen Title X in conjunction with school-based health centers. And now we're really going to focus explicitly on Title X. And we're looking at the 2016 to 2018 period for a reason, which is that there were large changes to the Title X program under the previous administration. And we wanted to create a baseline of what's going on in community health centers and with the Title X program before those changes. I'm going to turn this over to Fran to explain a little bit more about the Title X policy changes and present this work.
Thanks so much, Blair. Next slide, please. So as we got a wonderful introduction to earlier, there are basic requirements for participation in the Title X program for clinics receiving Title X funding. With the Trump administration, did away with several of those requirements and several of the fundamental requirements of the Title X program. So that it really ultimately weakened the quality of care for a distinct time period. So it did away with the requirement for evidence-based pregnancy counseling, banning abortion referrals. It did away with the requirement to have FDA-approved methods. So providers that only relied on natural family planning were then allowed to enter into the Title X program. And it also did away with adolescent confidentiality provisions around their choices of reproductive and sexual health care. These massive disruptions to the Title X program occurred in 2019. And before that, as we discussed earlier, the Affordable Care Act was very important in the context of contraception provision. So this study really seeks to capture the snapshot of time between the passage of the Affordable Care Act and then actually before the Title X rule changes mandated by the Trump-Pence administration. And I will just say that the Biden-Harris administration has reversed a lot of these changes. So even more importantly, understanding what happened during this period of time, so we can either see reversal or how trends have changed through this entire process of ebbs and flows in mandates for the Title X program, will be very interesting. Next slide, please. So in this study, we seek to quantify the baseline contraception provided by CHCs in both Title X and non-Title X funded clinics in a post-ACA pre-2019 landscape. So the outcomes for this study were most and moderately effective contraceptive provision in women at risk of pregnancy. Next slide, please. When we focus here on most effective or LARC provision, the figure on the right describes the adjusted rate of contraceptive provision per 1,000 women per quarter. We are trying to see if there were time trends involved in contraception provision with the hypothesis that they might change over time. This figure doesn't really show it that much. We still prepared the figure and it's in the upcoming publication, so we present it here. But the time trend hypothesis didn't necessarily pan out. So if we just focus on the overall trends, though, Title X funded sites are the blue triangles and non-Title X funded sites are the yellow squares. So we can see that Title X funded sites provided about 52% more if you quantify the difference between the triangles and the squares, about 52% more most effective contraceptives to women at to women at risk of pregnancy compared to those at non-Title X funded sites. Although we don't just show the data here, it's in the upcoming publication, the finding was especially notable for adolescents. Next slide, please. So if we compare most effective and also moderately effective, which is not described here for time, but clinics that receive Title X funding consistently provided access to most and moderately effective contraception at higher rates. So 52% more most effective and 49%, sorry, oh goodness, my cat jumped in. 49% more moderately effective contraceptives than CHC clinics that do not receive Title X funding. Next slide, please.
Thank you, Fran. So now I just want to back us up and think about the takeaways from this developing body of work. And I really want to start with how do these studies improve on previous work? We had evidence prior that the Title X program provides enhanced access to family planning services, for example, but we only had that at clinic report level, right? At the aggregate level, reported up to the OPA, or we had it for a specific state. There's some data out of California looking at the Title X program in California specific. So the OCHIN and advanced data allow us to look at the individual level and look across states. And a key piece is that it allows us to see utilization among people without insurance and compare them to people with insurance. If you're looking only within Title X clinics, very few people are using, Title X exists to fill gaps in insurance. And so you sometimes don't get the chance to compare them to people with insurance and across the safety net. So it's been just a real privilege and pleasure to be able to leverage the OCHIN and advanced data to look at these questions. And again, and in addition to the individual level factors, we can also look at these state and federal policies and programs because we do have variations across the participating states. So in terms of our findings, we find that community health centers are key access points for contraceptive care for women and adolescents with low incomes, and that's both CHCs that participate in Title X and CHCs that do not. But we do see that CHCs that receive Title X funding provide enhanced access to, especially to the most effective contraceptive methods, LARC methods, IUDs and implants. And we see that Title X is especially important in states that did not expand Medicaid. And this is a very policy relevant finding because there was some debate about, once Medicaid is expanded, do we need the Title X program? Do we need these state family planning programs anymore, now that we've expanded Medicaid access to more women with low incomes? Our findings suggest that although this fragmented system is not the one that I would have designed if we were starting from scratch, that these programs are still filling important gaps in access to contraceptive services. So we have some ongoing work in collaboration with Fran and Emily and Erica Cottrell and the Every Woman team, where we are looking at specific methods. So you saw in the school-based health center study, we separated out IUDs and implants. The reason we did that in that study is that previous work shows that adolescents tend to have a preference for implants over IUDs. So we wanted to look in that adolescent population at specific methods. Now we want to look at that same question across CHCs, not just in SBHCs in Oregon. We're interested in looking at discontinuation and switching. There's been some concern in the field that as more women choose LARC methods, that they also have access to discontinue those methods, since they are not patient controlled methods, right? You need to go back to a clinic to have your IUD or implant removed, although there's some data around IUD self-removal, but implant self-removal is next to impossible. So we want to look at discontinuation and switching. Are we seeing the rates we would anticipate in the CHC population, which would indicate that there's equitable access to discontinuation of LARC methods? With Erica Cottrell, we're thinking about a study that looks specifically at state immigration policies and utilization of services, thinking about effects of people being concerned to seek care based on their immigration status or a family member's immigration status. As with every clinical area during the pandemic, telehealth has really taken off in reproductive health services. And so we're interested in looking at that. And there's some more key populations where there's remaining work to do, such as adolescents, or looking specifically at Spanish speakers, for example. And finally, Fran has been working with Sophia and Shane and Ochin to think about integrating Title X access into the advanced data warehouse. One of the limitations, and Ochin and advanced data have many, many strengths. They also have some limitations. One of the limitations for looking at Title X in these data is we don't have equal coverage in all states. So for example, we have a lot of clinics from Florida. We do not have one single Title X clinic from Florida in the data set. So we're interested in trying to map proximity to Title X, similar to the way Emily explained in the school-based health center, we accounted for proximity to a Planned Parenthood, trying to get a sense of where there are other services that might be nearby that aren't in our data set, but that would help account for some of what we're seeing in the data. And the other thing we cannot see in the EHR data is what happens at counseling visits. There's a lot of interest in the field in ensuring that person-centered contraceptive counseling is indeed taking place, but that is not something we can see in the EHR. I know some Ochin clinics are participating in a pilot of the person-centered contraceptive care quality metric, which was also just recently endorsed by NQF and is meant to be a companion to the claims-based measure of access to LARC, and is focused on 4 items that ask patients about their experience with care and really try to get at whether patient-centered counseling from the perspective of patients is happening. So it'll be really exciting to see the results of that work and maybe see that metric implemented more widely across Ochin clinics. I want to thank all of the people who have been instrumental, not only to these studies, but to really supporting this program of research from the beginning, which was, as I said, it's been over 5 years we've been working on this. So Erica Cottrell, Megan Hoops, G. Oakley, and the entire Every Woman team, and Fran is part of that team here presenting today. At Ochin, Vance Bauer and John Heinzman have both been real supporters of this work, and I really appreciate their support and enthusiasm and mentorship. My colleague Maria Rodriguez here in the OBGYN department at OHSU is a key collaborator on this work. And I want to thank our collaborators at the Oregon Health Authority. On the school-based health center paper we presented today, they were absolutely essential to helping us understand what these clinics are like on the ground and what the politics and policy issues are around school-based health centers and contraceptive services. So really played a key role in interpreting data, as I'm sure all of you who are in clinics do when you're participating in research. It's just so key to have people who are on the ground. And finally, thanks to all of you, to the Ocean Advanced Clinics who make this kind of work possible. And our funders. So I just wanted to highlight that we've had a variety of private and public funders for this work. And I think that's what it takes to kind of keep an ongoing program going, is diversifying funding and getting creative about where you can find funding for the work. So starting way back with an internal OHSU trainee grant is what really got my first introduction to the ocean data. And I am still learning more about it every time we do an analysis. And so I so appreciate all my collaborators' expertise in the data. So thank you to our funders. And thank you all for your attention. And now I would love to hear your questions.
All right. Thank you very much, Dr. Darney, Emily, and Fran, for that presentation. And if attendees have questions, please type them into the Q&A or chat box. And we're going to start things off with Megan, who asks, what was the data source for the SBHC analysis?
Emily, do you want to take that?
Yeah, so my understanding is that all of these analyses are based on OCHIN data. One of the reasons that our SBHC analysis focused in Oregon is not only does it have a really robust system with a lot of school-based health centers in Oregon, but quite a few of them are participants in the OCHIN system. So we were really able to get a decent sized sample focusing in Oregon. So we had 33 total SBHCs in our sample. And there are other school-based health centers that don't serve adolescents in the OCHIN system as well, but obviously they weren't included because they were not serving our target population.
Thank you, Megan, for that question, and thank you, Emily. And next up, we have Nicole Cook, who says, first, thank you for studying the changes in Title X, and asks, do you have any sense from your work on implications on Supreme Court rulings on allowing religious/moral exemptions to coverage of birth control?
Yeah, that impacts the private sector a little bit more than the publicly insured sector. So although an entire institution like a religious university, right, could say we're not going to cover contraception for any of our employees, that's in the private insurance market. So there has been some work looking not so much at the insurance market side of it, but looking at Catholic hospitals and the kinds of services that are and are not provided in Catholic hospitals. And that happens both with sterilization and contraceptive services, and it happens with end-of-life care, right? For hospitals that are under the Catholic directives. And as hospitals are merging, which they are across the nation, a greater chunk of all of our hospitals in the country are under the Catholic directives. So I think there's been a little more attention to reproductive services and religion kind of in that field, and less in the CHC population, where we do see privately insured individuals, but that's not our main focus, if I've understood that question correctly.
All right. Thank you, Dr. Darney. And thank you, Nicole, for that question. Up next, we have Dr. Marion Sills, who says, thank you for such a great presentation. And she asks, are there mechanisms by which state-level policies driving varied access to abortion services might impact contraception-seeking behaviors?
Yeah, that's a really great question. Of course, is on a lot of people's minds, especially as we see what the decision is in the Mississippi case. So states are taking action. I'm proud to say that Oregon is taking proactive and progressive action. The Reproductive Health Equity Act, which was passed in Oregon, for example, expands prenatal care to undocumented and new immigrants who are not yet eligible for Medicaid. It also covers abortion services for that same population. Oregon was already what's called a Medicaid state, where we use state funds to provide abortion services under Medicaid, because Medicaid is a federal program under the Hyde Amendment, cannot pay for abortion services, but states fill that gap with their own funding. And then Oregon's taken the extra step under REA to fill the gaps of funding for people who are not covered by Medicaid. And in terms of, you know, you might hypothesize that as abortion becomes scarce, harder to access, people will be more motivated to use contraception, but history has not borne that hypothesis out. We will always need abortion services, and we want to help everyone prevent pregnancies they want to prevent, and then we want to help everyone prevent births that they want to prevent.
Thank you for that question, Dr. Sills, and thank you, Dr. Darney. If people have questions, please enter them into the Q&A or the chat box. The next one comes from Arwen Bunce, who asks, where do contraceptive injections fit into this?
Oh, that's a great question, Arwen. Thanks for bringing that up. They fit into the moderately. So Depo-Provera, or DMPA as it's known, contraceptive injection, is a short-acting hormonal. It's not short-acting the same way a contraceptive pill is, because you don't take it every day, but that's where it gets classified. And those classifications come from efficacy rates of perfect use studies that have been done, that if someone uses a method perfectly, what's the chance of a pregnancy within a year? And then typical use, because in the real world, contraception is not as effective as it is under lab conditions, right? Depending on user error, basically. So DMPA fits into moderately.
Thank you very much. Dr. Sills asks, how do you optimize the policy impact of your policy research?
That is a great question, and I would love to partner with Ochin on learning more about how to do this. I like to think about that question in terms of, that's why I like to work on teams. I do what I do, and I'm not an expert in kind of how do we get the policy messages out to the people who need to hear them, right? In some of my work in Mexico, where I partner with nonprofits, we generated policy briefs, and then the nonprofits kind of take that and run with it and get it into the hands of policymakers. So I really welcome partnership and teamwork around thinking about the best way to do that. Of course, if all our policy were driven by evidence, we'd be in a much different place. We all know that, but it always is important to get this evidence into the hands of policymakers.
All right. Well, we have a few more minutes left, and if people have questions, please type them into the Q&A or the chat box. We have a question here that asks, in your research, have you noticed, are there differences between urban and rural environments regarding the decline of unintended pregnancies and access to contraceptives?
That's a great question. There has been some work around what's termed in the literature as contraceptive deserts, right? So similar to access to all kinds of healthcare, people living in rural areas have limited access. Again, the Ochin advanced data are so rich, and yet when we start to drill down and slice and dice, like Title 10 by rural, we start to get into some small numbers, and it's hard to say something really definitive about urban and rural, I would say, in our studies. But we do know that, like everything, women in urban environments have much better access to contraceptive services, just like they have better access to all kinds of health services.
All right, thank you. Well, this will be the final question. I just want to say congratulations on the Title 10, 2016 to 2018 manuscript being in press at Health Affairs. Do you know when this will be published?
I think it is slated for the spring, and I can't remember if it's March or April, but we will definitely let you know as soon as we know.
All right, thank you very much. And thank you, Dr. Darney, Emily, and Fran for that fantastic presentation. And thank you to everyone who attended today's session. Be sure to follow Ochin on Twitter at Ochin Inc. and over on LinkedIn. In addition, head over to ochin.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And don't forget to check out our Ochin YouTube channel to catch up on past Grand Rounds presentations. And stay tuned for next month's Ocean Grand Rounds, which on March 17th, we welcome Dr. Patrick J. O'Connor and Dr. Joanne Spurl-Hillen of Health Partners Institute and Dr. Rachel Gold of Ocean as they present on CV Wizard, using a clinical decision support tool on cardiovascular risk management in CHCs. Invitations to this event will be sent 2 weeks prior, but if you're not on our mailing list and are interested in attending this or any future Grand Rounds event, please email me at grandrounds@ocean.org. That's grand rounds, all one word, at ocean.org. So from all of us at Ocean, and from Dr. Darney, Emily, and Fran to all of you, have a wonderful rest of your day and stay healthy out there.
Thank you.